Before we get started, I will quickly review a few housekeeping items. First, this call will be recorded for training purposes. I will provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end as time allows, and I will provide you instructions on how to unmute your line. Now I will introduce the speaker. We are very pleased to welcome Stefan Gravenstein, who is a well-known nationally and internationally for his work in the immunization field. He is Clinical Director of Quality Improvement at Health-Centric Advisors, a Professor of Medicine and Clinical Director for the Center of Geriatrics and Palliative Care at Case Western Reserve University, an adjunct Professor of Medicine and Health Services Policy and Practice at the Warren Alpert Medical School of Brown University. Dr. Gravenstein has a long-standing interest in immunity, inflammation, and aging, especially in the context of influenza and nursing home care. And these are the topics of the majority of his publications.
Appreciate everybody's tolerance of our technical difficulties. Hopefully we'll make up for it here. I'm going to go through the slides a little faster than planned, but you'll still get the key points. We're going to talk about adult vaccination against flu and pneumococcal infection.
9 minutes.
Who to vaccinate. We'll talk about the role of immunosenescence, a disease in vaccination, contrast the new pneumococcal vaccine with the older one, and ways to improve immunization rates. Vaccination began back in 1796 with something called variolation, where you gave live virus to... I hear talking in the background. Just... that was given cowpox virus into an open wound that was made by scraping the skin and using that to immunize against smallpox. Since then, we've come a long way, discovered antibodies, cellular theory of aging, and finally conjugate vaccines. You can see in the last decade, there's been a whole bunch of new vaccines, so the pace has been accelerating. So there's lots of benefits to the vaccines to prevent symptoms or disease in the first place, so they don't get infected, or even if they get infected, that they don't present clinically. If they get symptoms, to reduce the severity, reduce complications from the disease, keep it from spreading from one person to another, and potentially control or eliminate entirely. You can do that, for example, with diseases that are only carried in people, like pneumococcal disease or pertussis. So we have a responsibility to educate our patients, know when not to give the vaccines and what to be careful about, and to give them when they're due based on the current recommendations. We also have a responsibility to report adverse events when we give vaccine, and I'll tell you about how to do that. The Healthy People 2020 target for influenza and pneumococcal vaccines is to achieve 90% vaccination coverage. And you can see from these graphs in the last decade, from 2003 to 2013, we haven't been anywhere close to that for the population as a whole. For the high-risk groups, the target's a little lower, but you can see either way we have a long way to go. There's also disparities in how flu vaccine coverage works. Here you can see that Caucasians have better uptakes than Black, Hispanics, or Latinos. So there's cultural differences in how we accept vaccine, a barrier we have to overcome. There's also a difference in poverty. The people who are below the 100% poverty level have lower vaccination rates than those in the higher groups. Currently where we are as of last year, for flu vaccine, we've only had 65% coverage for those over the age of 65, the group we've been working on the longest. And other than hospital staff, for healthcare workers and high-risk adults, we're much lower than that. So we have a long ways to go. So there's a professional ethic. There is identifying high-risk groups and figuring out how we're supposed to get them vaccinated. Is it the primary care doctor's job or the specialist job? And how do we make everybody work on this together? So in this slide, you can see for pneumococcal vaccine, we are no better. It's a 90% goal for those over the age of 65. In the high-risk groups, we have a long way to go. There's an image here of both influenza on the left and the bacteria, Streptococcus pneumoniae on the right. These are completely preventable diseases, and vaccination is our best path forward. If you go to this website from the CDC Vaccine Schedules, you can find these images. They're going to be a little hard to read if you don't have high resolution on your screen. But essentially what you should see here is 6 months and up, you should be getting the flu vaccine when you base this on age. And for pneumococcal vaccine, you could get doses before the age of 65, 1 or 2 for the polysaccharide, 1 maximum for the conjugate vaccine. And then after age 65, you could get another dose of either or both. For conditions, it's a little bit more complicated, and you can see the conditions aligned across the top. Immunocompromising conditions, pregnancy, HIV infection, kidney failure, heart disease. So these are the high-risk conditions that are true for both flu and pneumococcal disease. And you can see either way you're supposed to be giving the flu vaccine annually for these high-risk groups. And for pneumococcal disease, you'd be giving them for these high-risk conditions also below the age of 65. Again, if you look at the schedule, you can see in some cases it's 1 dose, and in other cases it's 2 doses. So let's talk about a very brief case. Here you have a gentleman who's 65, who comes to the emergency room, and he has a productive cough with yellow sputum, fluid chest pain, mild to chilling fever. 6 days ago, when his symptoms began, his doc diagnosed flu. We also know that flu is circulating in the community. His symptoms improved, now they worsened again. He has diabetes and kidney disease. He's up to date on his tetanus vaccine and his diphtheria vaccine 5 years ago. He has a fever, he's breathing fast, he has rales and hypoxia. So the question is, Mr. Smith has at least 3 indications for influenza vaccination. True or false? So you should be choosing one of these answers and they'll show up on this screen. Okay, I'm hoping folks are submitting. And the answer you should be getting here is this is true. Age is a condition by itself for flu vaccine, but he also has diabetes and kidney disease. So this would be true. So risks for complications for flu, you can see here's the spread. We had a few folks that said false, and I'm guessing that those that said false were not counting age as a high-risk condition. The first of these high-risk conditions, residents of chronic care facilities would also count. Chronic conditions like lung disease, diabetes, that's a metabolic disorder, heart disease, kidney dysfunction, hemoglobinopathies, HIV infection, immunosuppression, including cancer. Pregnant women are relatively immune suppressed. This is especially true in the second or third trimester. Morbidly obese are at high risk because their obesity makes it harder for them to cough and clear secretions. They have reduced residual volume. Children 6 months of old to 18 years old, if they're on aspirin therapy, have a risk for a rare disease called Reye's syndrome. So if they're on aspirin, they have a virus condition, and therefore they're at risk for complications. It's a flu vaccine, which makes the world confusing. There's the trivalent and the quadrivalent. Of the trivalent version, there's the inactivated formulation, which we call IIV3, which the 3 makes a trivalent, and that can be either given in the muscle or in the skin, intradermal. The intradermal version has a very short, very small needle, so it only goes into the skin and not any deeper. There's a new formulation out since 2009, which has a high dose for individuals over the age of 65. And finally, there's a recombinant version out. The recombinant version differs from the other ones in that the recombinant version is not grown in eggs. So egg allergy people can get this vaccine without worrying about their egg allergies. The quadrivalent vaccine, everybody's gradually switching to quadrivalent. It's now also, there's an inactivated formulation that's called IIV4. That's only given intramuscularly. There's also a live attenuated vaccine, LAIV, that's given intranasally as a spray. It doesn't contain any thimerosal or other preservative, and it isn't grown in eggs. So it has age group restrictions. Only RIV has no egg placing, single-dose preservative-free syringes, and multi-dose vials. Single dose are typically preservative-free. The multi-dose vials have preservatives in them. So anybody over the age of 6 months should be vaccinated. If they're healthy, including pregnant women and those with Hives-only allergy to eggs, you can give the inactivated vaccine. For the 2 to 49-year-old group, without high-risk medical conditions, you can give the attenuated vaccine, give the recombinant vaccine, including in people with egg allergy. For intradermal, age 18 to 64, for high dose, greater than 65. And healthcare vaccine personnel can get the inactivated vaccine, 5 or quadrivalent, or the recombinant vaccine. If they're caring for immunocompromised people, and they're given the live vaccine, they should avoid contact for 7 days after vaccination. Children who get the live vaccine can shed virus for up to 3 weeks. So the new changes for 2015, the contraindications for or precautions for the live vaccine have been expanded to not use it if you've had antivirals in the prior 48 hours. And they've relaxed it from a contraindication precaution for the high-risk conditions. Also, for the recombinant vaccine, it's been expanded now for everybody over the age of 18, not just 18 to 49. So how good the vaccine is depends on how well it's matched to what's circulating in the community. If you've had prior immunity from the specific infection from the prior year's immunization or infection, how much the virus has changed, how old you are, and the overall health or high-risk conditions. If the match is very good, it's very effective. It can be 60 to 75% effective in preventing clinical flu, less so for age group 65, though it still can be pretty effective, 50 to 60% reduction in influenza-related hospitalization in those over the age of 65, 80% effective in preventing deaths from flu in people over the age of 65. As you get older, your body is less permissive for infection, including pneumonia, and if these are more likely to become severe infections that can result in hospitalizations. As you get older, you have less of a vaccine response, so you don't get quite as much protection as when you're younger, and you recover more slowly from infection. As you get older, your symptoms for disease also change. So a way to think about this is when you get infected, or when you get a vaccine, when you get infected, the blue dots here represent the virus that comes from flu. It stays in the lungs, but you may know that with flu you can get muscle soreness or myalgias. You can get headaches, you can feel run down and just feel weak all over. That's not because of virus that gets into the muscles or the rest of the body. It's because we produce an immune response to the virus, cytokines that go throughout the body. They cause the muscle aches, the soreness, the fatigue, the malaise, and so forth. So it's not infection through the body, but cytokines. As you get older, you produce less of these cytokines. So even with the same severity infection, you tend to look less sick, even if you're going to end up dying from it. So recognize that older people are less symptomatic, and so if we use strict criteria such as high fever to diagnose flu, you will miss a lot of old folks that have influenza or other infections for that matter. The second thing is from old people are also more likely to have certain types of complications not present in young adults or children, such as heart failure, heart attack, and stroke. In this particular study, if you look at the middle two rows, hospitalization for acute coronary syndrome, hospitalization for heart failure, and then glance far over to the right, you can see that there's roughly a 30% reduction for hospitalization for heart attack, and about almost a 40% reduction in hospitalization for heart failure in these people who are vaccinated versus those who are not vaccinated. So it prevents major cardiovascular events. Hospitalization for flu increases at age 50. You can see the bars here going up and below the age of 1. But you can see the majority of hospitalizations on a per 100,000 population basis occurs in the oldest individuals. The CDC estimates of influenza mortality in people who have a label of pneumonia and influenza, 8% of them are actually dying from influenza. If they have a diagnosis of dying of respiratory and circulatory death, 2%, that's a much bigger number, 2% of those are thought to be directly due to flu. So the majority of deaths occur in those over the age of 65 and are often as a complication of a secondary infection or other comorbid conditions such as heart disease. So in the top left here, you can see from 76 to 2007. 65 that were most likely to die from underlying pneumonia and flu. And the bottom right, the bigger group underlying respiratory and circulatory causes. You can see over 65 makes up an even bigger group. That group is 3 times the size of the folks that just get pneumonia. So the vascular outcomes are actually a more important outcome than just pneumonia from flu in late life. The reason for this is that the cytokines that we get from a response to infection go up, and when those cytokines go up, they tend to make the blood clot. If you clot in your heart, it's a heart attack. If you clot in your brain, it's a stroke. So there's an experiment done by Zeng on this particular slide that shows the degree of inflammation that's caused with, in this case, an experimental flu infection, and it increases inflammatory markers such as TNF-alpha and COX-2. And they also showed that giving COX-2 inhibitors might improve the pathologic features of the lung, lower the inflammatory cytokine concentrations, and less of the T-cell lymphopenia that comes with infection. In this article from Sneeze, this was in 2004, they looked at 21,000 people who had a first heart attack and 20,000 with the first stroke. They also had a separate ones where they were looking at subsequent heart attacks and strokes. And they showed that after vaccination, there's no increased risk for heart attack or stroke. But after infection, including a systemic respiratory tract infection or bladder infection, there was an increased risk of heart attack or stroke that was 2 to 4-fold higher in the first couple of weeks, and that elevated risk was sustained even though it was ebbing as long out as 3 months. So infection, including flu, respiratory infections of any kind, bladder infections, are all things that drive outcomes of heart attacks and strokes, and you can prevent a subset of those with vaccination. So here is a dose where they compared high-dose flu vaccine against an active comparator, standard dose vaccine. And I want to remind you that this is an active comparator standard dose vaccine when it's well matched. Remember, it can reduce cardiac and pneumonia and influenza outcomes by 60%. If you give these older individuals high-dose vaccine, they have a 24% added reduction of laboratory-confirmed clinical influenza. So the high dose seems to be superior in a relatively healthy group of older folks. There was a second study sponsored by the FDA, CDC, and NIH, which looked at this, looking at Medicare claims data. And the left curve here shows the high dose against standard dose and they showed the rate per 100,000 people who got a rapid test and then a flu treatment was 22% less likely if they had gotten the high dose, meaning they were less likely to be diagnosed and treated for flu, pretty close to the 24% number. On the right-hand side, a similar one, but in this case, they had an influenza inpatient hospital admission, also about 22% less. So you can see that there's some evidence that high dose is more effective than standard dose at preventing hospitalization and flu. So here's your polling question. You have a 68-year-old black female who's here because the spouse was hospitalized for flu yesterday. She has kidney disease. She had a friend with bad flu after vaccination. History of severe hypersensitivity reaction following exposure to duck feathers, but she does eat eggs. She now has allergic rhinitis. The mother had grand mal seizures. So the first of this series of questions is, flu can cause a heart attack or stroke in an older patient. True or false? We still have 10 seconds to submit your answer. And in a moment, we'll show the results. Okay, the question is, flu can cause a heart attack and stroke in an older patient. I'm looking for the results to show on screen. The answer to this is true, that I showed you that on. And in a moment, we may see that polling result. I'll go ahead and go on to the next question. You can see that 63% got that right. Again, 8% generated the incorrect answer. Yes, it can cause heart attack, stroke, and what's more is vaccine may be able to prevent those. All right. Second question, same patient. She should not get the vaccine due to her feather allergy. True or false? Polling question, please. I'm hoping everybody submits an answer this time. We had 18 who did not. So I'm hoping for the polling answer to show up soon. The answer to this is false. Feather allergy is not a reason to get the vaccine, to not get the vaccine. I want to show you the next question here, same patient. The influenza vaccine can cause influenza. I'm ready for the polling question to come up, true or false? Okay, so this is closing it. So we're waiting for the answer. The answer to this is false. There is no live virus in the flu shot. In the live inactive, the live attenuated influenza vaccine, you can get sniffles, but you don't get influenza. So the answer to this would be false. Okay, so good. Most of you got that right. Recommendations for patients who report egg allergy. So the short answer to this is, even if you have an egg allergy, you should be vaccinated. The top left is if the allergy is mild, meaning you can eat a cooked egg without a reaction, you can get it just the way you usually get the vaccine. Just watch them for however you normally watch them. If after eating eggs or egg-containing foods, no more allergic reaction than that, you can still get it. Here you have the option of the recombinant vaccine that isn't made with eggs, or you can administer it and watch them for 30 minutes but have your allergy kit available. If it's worse than that, if after eating eggs or egg-containing foods you have anaphylaxis, symptoms of anaphylaxis, you can still vaccinate them, but you might want to give them to a specialist to do this. So one way you can vaccinate them is give them the recombinant vaccine that is made with eggs for ages 18 and up. It needs to be updated because it's now all age groups above 18. If the trivalent vaccine isn't available or the patient's under 18, you can use an experienced physician to give this, so you want to refer them. And also you want to observe them for at least 30 minutes. But in all three cases, they can still get the flu vaccine. So to which components of vaccines are people most commonly allergic? Egg is the most common component for flu vaccine, and we have now the recombinant vaccine as anything with egg. In the shingles vaccine, it's gelatin, and hepatitis vaccine, it's yeast, and hepatitis and meningococcal vaccine, they have latex in them. So those are the things that you need to know about vaccines. So the adverse effects for flu vaccine is a local injection site reaction. 15 to 20% will have some soreness in the site where they have the injection or redness. With the intradermal vaccine, there's usually less soreness and more redness. You can get malaise, fevers, chills, myalgias. Remember, that's from the cytokines that are being produced against the vaccine. It happens at the same rate that a placebo is given. Allergic reaction is rare. Thimerosal can potentiate hypersensitivity, but this is usually a type 4 delayed sensitivity, so it doesn't happen while they're in the office. Guillain-Barré is really uncommon, 1 or 2 cases per 100,000, so we're not sure what the risk is. Back in '76 with the swine flu, there was a suggestion that the Guillain-Barré that occurred in a few cases there might have been related to the swine flu vaccine. If the person has to develop Guillain-Barré within 6 weeks of a prior vaccination, then you don't want to give them the vaccine. So that probably won't be anybody that you'll see in your practice. So inactivated virus can't cause the flu. If you have a reaction, you should report this to the Vaccine Adverse Event Reporting System called VAERS. And you can see that this was an injury act, and it's a place whether or not you think it's related to the vaccine. If they have something that happens shortly after vaccine, you should report it here, and that's the way we track it nationally. In Rhode Island, the Department of Health pre-orders flu vaccines for providers, and you can see they have a panel of different vaccines available. The one vaccine that they might not order if there aren't enough people asking for it from the state would be the FluMist, the live attenuated vaccine. They have to hit a threshold number of orders before they'll get it because they get it, I think it's because they get it at a discount. Here's a polling question. We have a 49-year-old white female who just started hemodialysis for her nephropathy from her diabetes. The last vaccines were she completed when her DTP and her MMR and polio vaccines when she was a child. She should have the pneumococcal vaccine, true or false? Polling question is up. Please submit your answers. We still have 10 seconds. 2 seconds. Okay, we're going to close the polling. So the answer to this is true. She has a high-risk condition for which she should get her pneumococcal vaccine, so she would qualify for this. In a moment, we'll see the polling answer. And here you can see the vaccination schedule. The lines are a little skewed here. At the top, we have flu, and the bottom, pneumococcal vaccine. And you can see in the boxed out area, kidney failure, end-stage renal disease, receipt of hemodialysis, are all reasons to get a pneumococcal vaccine. And folks got this right. Congratulations. Excellent response. Okay. So how common is Streptococcus pneumoniae? There's an invasive and non-invasive. Invasive includes only diseases where you get bacteremia, so that's bacteria in the blood, or meningitis. Either one of those makes up invasive disease. If you don't have either one of those, it's non-invasive. And for non-invasive disease, we are specifically talking about pneumonia and acute otitis media. So for invasive disease has a high mortality rate, 20% in elderly, straight up mortality from pneumococcal bacteremia, 22% mortality in adults for meningococcal disease, 8% in kids. For non-invasive disease, 36% of community-acquired pneumonia is from pneumococcus, and 100 to 400,000 hospitalizations occur each year due to pneumococcal pneumonia, with a 5 to 7% mortality rate. Higher in old folks. In fact, old folks make up the majority of that. So in patients 1864 with hematologic malignancies, there's a substantial rate, as there is with HIV. Typhoid vaccines induce a B-cell-dependent immunity, and so as you get older, it doesn't work quite as well. So for this reason, they've developed a conjugate vaccine. The 23-valent polysaccharide vaccine is 60 to 70% effective against the invasive disease, that's the bacteremia and meningitis. It's less effective against plain old ordinary pneumococcal pneumonia, in other words, non-invasive disease. The conjugate vaccine, that's the PCV13, earlier generation was PCV7, with only 7 antigens as opposed to 13 antigens in the PCV13, compared to 23 in the polysaccharide vaccine. The conjugate vaccine gets both B and T cell immunity and a better memory response. So this involves mucosal surface, so it helps with localized non-bacteremic infection better than the pneumococcal vaccine. And the PCV7 reduced invasive disease by 97%, confirmed pneumonia, otitis media, and so forth, and in nasopharyngeal carriage, which is the where it's carried to be transmitted from one person to the next. So if you look at the 3 vaccines, PCV7 has 7 antigens, PCV13 has 13, and PPSV23 has 23, and you can see the percentages of pneumococcal disease that each of these 3 vaccines covers at the various age groups, and you can see the 23-valent has most of them, but PCV13 gets about 2/3 of those that are in the old-fashioned PPSV23, the one we've been giving for decades. So in 2007, the PCV7 was licensed for use in kids, and it was good against invasive disease. And it has indirect effects, and I'll show you those on this slide. So here you can see in the under 5 age group, when it was introduced in 2007, promptly with the introduction, the strains that were in this vaccine dramatically reduced the numbers of invasive pneumococcal disease. You can see that group just plummeting down. And even though the other groups weren't being vaccinated, you can see that the incidence of those strains in the PCV7 were less frequent even in the other age groups. So there was some protection conferred on the adults by the kids by getting this vaccine. Also, the changes in invasive pneumococcal disease specific by serotype. That's this slide. So the prior slide was generically invasive pneumococcal disease, and this slide is just the 7 strains that are in that disease. You can see they just hit rock bottom in 3 specific strains. The red is PCV7 type, and the blue is the non-PCV7 type, which didn't change much at all. And then 19A, which went up almost as it was replacing some of those strains that were no longer prevalent. So invasive pneumococcal disease by serotype group among older adults, you can see PCV7 serotype went down in older adults dramatically when this was given to children. So in 2010, the PCV13 replaced the PCV7 for children. So there's 6 additional serotypes. It's good for invasive disease. For those 13 serotypes, endocarditis media, and 7 serotypes common PCV7. There's also been a reduction in the penicillin resistance, which is pretty cool. So the question now is, what's going to happen in the older adults when this is now introduced to that population? There was a big study that was published last year, the CAPITA trial, which had 85,000 adults over the age of 65. This was done in the Netherlands as a double-blind, placebo-controlled trial. They showed a 45% reduction in vaccine-type community-acquired pneumonia, and they also showed a 45% reduction in non-vaccine-type community-acquired pneumonia, and 75% reduction in invasive vaccine-type pneumococcal disease. So pretty remarkable endpoints. Now, if this works in kids the way it had before, we may be eradicating the disease strains that are in these vaccines over the coming years. See, this slide is supposed to be on herd immunity, and you're supposed to see everybody in the blue is susceptible, and the ones in the red, if no one is immunized, the reds are the ones that get the disease, because it spreads among everybody. As you begin immunizing people, those are the guys in the yellow, there's fewer opportunities for them to get disease, but they're not actually protecting a lot of people. If you protect a lot of people, then fewer people can get the disease in the first place, and the rest of them don't have anybody to transmit it to them. So you could spread the ability to be contagious. So who gets the pneumococcal vaccine? This is age 65 and older and high-risk adults. If they haven't had a history of pneumococcal vaccine, you can give them the PCV13, wait 6 months to a year, and then you can give them PPSV23. If they've previously received the PPSV23, the polysaccharide vaccine, you wait at least a year to give them the PCV13, and then you can give them another 6 to 12 months and at least 5 years after their prior PPSV23 and give them the PPSV23 again. If they've received the PPSV23 at age 5 or older, you wait at least a year, and they only get the PCV13. And as of right now, there won't be any future vaccinations after that. And PCV13 usually might change their mind, but it could also be that the PCV13 becomes obsolete if coverage actually removes those strains completely out of circulation and nobody gets the disease anymore. I'm not quite that optimistic. This country, we still have people from all the other countries that come in as carriers that potentially reintroduce it to our population. So below, you can see underlying conditions, long-term care facility residents, chronic conditions, so forth. Still, PPSV23 is recommended. If they have on top of that immunocompromised chronic renal failure nephrotic syndrome, asthenia, then you have a regimen much like the middle one up on the top. So the summary is pneumococcal vaccine naive, you give PCV13 first, follow it with PPSV23 at least 8 weeks after or longer. If they've already had the PPSV, wait at least a year. If they've already had them both, you give them a second PPSV23 at least 8 weeks after the PCV13 and 5 years after the first PPSV23 dose. Also, right now, it's only 1 lifetime dose of PCV13, no more than two doses of PPSV23 before age 65 in very select groups, and expect most will get 1 dose of PCV13 and 1 dose of PPSV23 after age 65, what we should be expecting. So here's a polling question. Joan is 89 and received the PPSV23 4 years ago. She should receive the PCV13 now. True or false? Okay, waiting for that polling question to come up. Okay. 10 seconds. In a moment, we'll see the answer. So the answer is true. She hasn't received the PCV13. She's 89. It would also be true if she was 66. She should get the PCV13 now. We'll see who got that answer right. So the last component of our webinar is to talk about what you can do to improve your uptake rate. 63% got that right. Congratulations. That's good uptake. So she should be getting the PCV13. Thank you for that. The things you can do. The left side is what you as providers can do, or what you can teach providers to do. So chronic medical conditions are often overlooked. In fact, that's what we have the biggest opportunity to improve vaccination rate. They don't know the contraindications right. Egg allergy, you see, is not really a contraindication. It's a relative contraindication. Just have to give it differently for flu. There's no system to identify people due for vaccination, so figuring out how to develop a standing system. Standing orders aren't present, that's part of that system. And flagging in the EMR. So the system reasons can be there's not enough vaccine around, that happens every few years for flu. Lack of vaccine tracking systems, so you can't tell who's gotten it when. There's reimbursement issues, especially if they're under age 65, and then there's access difficulties getting to a place that has vaccine or getting to a pharmacy. We've overcome that in part by having pharmacies being able to get vaccines. Patient origin rate reasons, they don't know that they're due. They're afraid of needles or adverse events. They think they might get flu from the flu shot, as an example. They don't have a routine appointment. So all of these contribute together to getting low vaccination rates. What you can do is develop a process where patients come in as a standard intake in the office. You screen for whether they've been the vaccine. When they get admitted to the hospital or nursing home, you screen whether they've gotten the vaccine. If they come into your dialysis center, when you enroll them, you screen to see if they had to have their vaccines, and then you systematically work to get them up to date. So there's a sticky note or an electronic flag that tells you that somebody's due, and that stays up until the vaccine is given. Standing order for getting that vaccine given is important. So how do we do it? Protocol screen patients and standing orders to vaccinate. A reminder system. Put the vaccination discussion into routine office intake. Develop a quality improvement initiative for performance feedback, and have the office and the clinic or the dialysis centers compete with each other for how well they do. Improve access with reimbursements, healthcare coverage, multiple sites, home visits for homebound. And insurance companies should be feeling increasingly compelled to be providing vaccines that are in fact very cost effective. So improving provider access to records, vaccine registries, which is a political question. How do you improve it? You recommend it. So the way I do it in my office, I'll say, the nurse takes them in. Your doctor wants you to get the vaccine. If you don't want to get the vaccine, your doctor's going to talk to you, but he highly recommends it. And with that, most of them don't want to confront me with that, so they usually just say yes. And if it comes to that, having that discussion is important because it'll not just be that one vaccine, it'll be all the other vaccines they'll have issues with too. So when you have a provider recommend it, you can see the uptake goes up dramatically. So here's the flu vaccine recommendations as I told it to you already. Any questions? Okay. So this allows us to align the work we do with quality reporting, so meaningful use, the electronic clinical quality measures, ECQMs gets you to PQRS, which is preventive care for screening for influenza and pneumonia vaccination status for older adults. This is a value-based payment modifier, so it can get your payments up. Patient-centered medical homes and ACO shared savings programs, these are all things that you should be thinking about and doing. So the summary, none of the current adult vaccines have uptake anywhere near the Healthy People 2020 goals, 90%, except hospital uptake of flu vaccine in those hospitals, especially that have mandated vaccines as a condition of work or wearing a mask. So you can do that in your own office setting or in your nursing home and make it a condition of future employment. That's hard to do with people who are already employed. Flu and pneumococcal vaccines reduce or prevent disease and are covered by insurance. Older adults present differently and have consequences affecting cardiovascular outcomes. So we often don't recognize when somebody has an exacerbation of their heart failure, that it might in fact be flu, and if we had just gotten them vaccinated, we could have prevented that outcome. Likewise, when workers come to work, because we didn't vaccinate our healthcare workers, they become the vectors of disease in our offices and in our hospitals and nursing homes. Vaccines are effective in adults too with variable covers. Hepatitis and Tdap vaccine All of those are also recommended for adults, and specifically shingles vaccines in older adults, highly effective in reducing post-traumatic neuralgia. So we have to develop a systematic approach to getting vaccination status tracked, reminders and standing orders to meet the Super 2020 goals, and align with meaningful use. That's the end of our webinar, and I'm now open for questions.
Thank you, Dr. Gravenstein. That was very informative. Unfortunately, because of the technical issues earlier, and we apologize for those, we'll have people enter their questions in the chat, and we will make sure to follow up with you individually to make sure you get the answers. Thank you.
Thanks, everybody.